like to introduce to the audience to Dr. Rajiv K. Sethi, which is the president of the Institute of Neuroscience, director of spinal research, and director of complex spinal surgery at Virginia Mason Medical Center in Seattle, Washington. But he's also a clinical associate professor at the University of Washington, specializing in health service research in the health economics and also in outcomes methodology programs. So at the end, Dr. Sethi's strategic and operational leadership has led the field of spine surgery in quality improvement, including the development of the Virginia Mason Complex Spine Care Pathway, which received in 2014 the Mary L. McClinton Patient Safety Award and the Seattle Spine Team Approach. So I am very pleased to have you with us in this webinar related with the GEER Congress, where we have the possibility of sponsoring the Congress and also have you with us and talk to the audience. You are now have plenty of time to talk about mitigation, about mitigation the risk in the adult spinal deformity surgery.
Thank you, Salva. I'm going to share my screen and make sure that you can see that. Is that okay? Can you see that? Okay. Thank you, Salva, for your wonderful introduction. I am going to be talking about mitigating risk in adult spinal deformity surgery today. And particularly, I'm going to spend some time on some of the themes that we've really developed over the last decade. I think, obviously, two of the guys that I've worked with in your company very extensively now over many years, Salva and David, both of whom have become good friends of mine. So I know that we're all waiting for 2021 because maybe we have a much better world in 2021. So we're waiting for that. Here are my disclosures. So one of the interesting quotes that I'd like to just think about is, when I was on the board of the Scoliosis Research Society and Dr. David Polly was president, one of the things that we talked about was really simple. How do you stop stupid spine surgery? And how do we really improve the work that we're doing and take the work that we're doing to a much higher level? And I think that one of the themes of this work really has been how do we reduce complications, right? And when you say stupid spine surgery, it's not necessarily just the act of doing the spine surgery. It's not necessarily just the act of doing a laminectomy or the act of putting in pedicle screws or the act of performing the spine surgery. It's actually how do you think about who should have the spine surgery and in what situations they should have it in. So that's what I'm going to talk a little bit about. And value really is the outcomes of a certain procedure over the cost of delivering these outcomes. And value has become very, very much a important area of spinal surgery and an area that we really need to focus on a little bit more. Then there's a whole idea of cost effectiveness. What's actually cost effective? And if you look, a lot of our procedures need to live in a certain zone. And that zone is between $50,000 and $100,000 per quality adjusted life year. That's QALY, as you can see here in the bottom. And we obviously live in spinal deformity surgery way outside of this. I mean, we live in the several hundreds of thousands of dollars per quality adjusted life year. So that's really our challenge. And then the governments have what's called a willingness to pay threshold. The governments, that can include private insurers, that can include employers. So we're stuck with this situation of how much are they going to be willing to pay for these procedures as time goes on. At the same time, we have something called payer agnosticism. And what that is it's a shift towards a single standard of care And that's really what I think a lot of us want to do. Really, we want to remove a lot of variability and head towards a single standard of care. And provider organizations will need to embrace capitated payment models, population management principles, and we really have to do this in a very different way as time goes on. So this is not uniquely an American thing. I pulled some slides for us to look at the cost of spinal fusion surgery, and obviously adult spinal deformity surgery, the most expensive of all of these. But this is a big problem. And if you look at the United States, this is the utilization of lumbar fusion surgery in the United States. And you can see the population adjusted relative utilization over this period. And this has continued to increase even after 2010. But you can see that since 1975, there's a pretty dramatic relative increase. We can take our best diagnosis, which is spondylolisthesis. And if you look at the population adjusted relative utilization of surgery for lumbar fusion, in this case, lumbar fusion for spondylolisthesis, you can see that it has rapidly increased over time. Same for degenerative disc disease, and same even for cervical myelopathy and radiculopathy. So we can see the utilization of these procedures is increasing. This is the problem, though. The problem is the cost of the surgery, right? And complications and lack of risk mitigation is a big driver of cost, because when you think of readmission rates, when you think of failures, when you think of reoperations, and the things that we're going to discuss here in the next 40 minutes, these are all big drivers of cost. And so when we come with a new plan, we have to think about risk mitigation. Risk mitigation is a very important step for us. What are the reasons for stagnant value? Inappropriate surgery is a big one, right? And some of that might be misdiagnosis. Does somebody have a hip problem or a knee problem or a neuromuscular problem that was not recognized and they had spine surgery? Inadequate preoperative care is really a big one. That's really a big area of focus, because when you talk about risk mitigation, it's really this inadequate preoperative care that we have to talk about. Then there's the whole idea of suboptimal conditions, right? Which can include inadequate preoperative screening, lack of standardized perioperative processes. That's what I'm going to talk about in the coming slides, and an area for us to really think about the whole idea of standardization and risk mitigation going forward. So in North America, I think, as in Spain too, if I remember correctly, Spain is also has a declining birth rate, similar to Japan, and you have more and more elderly patients who are going to have these degenerative spinal deformities. So you're basically going to be, as we are, inundated with these patients, and there's increasing demand for these types of surgeries, but we have unsustainable costs and unsustainable complications. So that's going to be the area to go forward. Now, a lot of studies have shown us that non-operative management doesn't work in the case of adult spinal deformity, and that only surgery can provide really the improved health-related quality of life, HRQOL. Again, remember, health-related quality of life. You might hear that term more as we talk, but that's a really key area going forward. So in the United States, since the surgeons and the hospitals have not been driving the quality improvement, the companies have really decided on how to do this, and they really have taken some of this work quite far with the ideas of centers of excellence. People like Atul Gawande, who many of you have maybe read some of his books, became the CEO of the first healthcare insurance company for Amazon, Berkshire Hathaway, and JP Morgan Chase. He's now moved on to a different job, but this was really interesting. And really, spinal fusion surgery and its overutilization and its lack of preparation of patients really was a major topic of his writing in the early days. And this was something that really became a very interesting and celebrated article that people read at that time. So let's go back to spinal deformity surgery, okay? And one of the areas that we worked on last 10 years in detail was how to reinvent what we were doing. How can you go back and study a process and then reinvent it? And one of the areas that we use in detail is the Toyota production system. That's the Toyota improvement pathways to understand your current state, and then not only improve on your current state, but reinvent your processes. And that can include a deeper understanding of your current state. And I'll talk to you about what some of these events are. Okay, the whole idea here is we have to adopt standard work. We have to remove the variability, and then we will all improve. And that without standards, there can be no improvement. So this is really the key principle of a lot of this work. The Seattle Spine Team approach, which has become quite synonymous with quality improvement in spinal deformity surgery, is really the following. All people that come to this center require a multidisciplinary opinion, right? That opinion is now done by a virtual conference because of COVID, but prior it was a live conference. But now, tomorrow morning, this conference will be done in Seattle virtually because we have about 17 people who attend the conference. We now do it virtually. There's a mandatory completion of a patient education course, and then we give them an exam after the course. We use 2 attending surgeons that can include those trained in neurosurgery and in orthopedics. Obviously, orthopedics, we have in the complex spine team now, I think 3 orthopedic surgeons, 3 neurosurgeons. So we have an equal of both. We have an intraoperative standardized protocol as to how these patients are managed during the surgery. That includes coagulopathy management, that includes resuscitation, that includes areas where there cannot be variability from anesthesia provider to anesthesia provider. So we remove the variability there. And then we found that there's a 3-fold reduction in readmissions and 12-fold decrease in return to surgery after the first year. And really, we've written a lot about this. We've studied this extensively. We've published this over the last many years. This is what we call a systematic multidisciplinary initiative for reducing the risk of complications in adult scoliosis surgery. And we really feel that we use population health principles here. We use quality, cost, and value principles to do this surgery. And really, the way that we originally studied this was we looked at a population. We looked at a population of group health patients. Group health is a former HMO. HMO is called a health maintenance organization, which they have a certain number of patients they keep together. So we're able to look at the number of patients that came to, for example, a neurosurgery service and then actually had a spinal surgery from there. And then we're able to actually look at how you can take the principles on the left, which are the Seattle Spine Team principles, which are multidisciplinary clearance, 2 attending surgeons, dedicated teams, to reduce all of the intraoperative and difficult complications that you see on the right side for us to get to a much, much important and better level of care of these patients going forward. And you can see from this data that we get the biggest improvement in the first 30 days. What does that tell you, right? That tells you something very important, that we are removing some of the worst complications like infection, like heavy bleeding, like major medical complications like pneumonia, like major cardiac events, strokes, etc. This is all happening in the first 30 days, and this is where we're seeing a lot of the importance, right? And so what this led, these couple of first studies that we did led to in our brains was spinal surgery has a long way to go, particularly complex spinal surgery in adults. Adult deformity surgery has a problem, right? There's little standard work. In the United States, more so than Spain, we have perverse incentives because the more we do, the more we get paid. And that's a problem, right? Private payers and governments are fed up of what's happening. They say we need change. I think the surgeons and doctors like myself have really led the charge to say we must understand healthcare economics and delivery as surgeons so that we can understand how to do this better. And the system will win, not the doctor, but the system. And that's really what we've talked about, right? And if we go back to this piece that I showed you earlier, which is that elderly patients are going to be increasing, their spinal deformities are going to be increasing. We really need standard work. Standard work will help us do everything, right? So if we go back to a basic method to study your own system or to study how you're doing things, if you look at the 7 wastes of the Toyota production system, that includes time, defects, motion, transportation, overproduction, inventory, and processing. Let's think about ways, if we take of this waste, what's called a waste wheel, time, right? We can think about something like processing, right? We can think about defects. Are there defects in your system? Defects are ways that you're making decisions. Is that defective, right? Overproduction, right? Overproduction means you're doing too much spinal surgery, or you're doing it in unnecessary amounts. Inventory, right? How much, you can even study your supplies in your cases. Or you have 4 surgeons that are doing it 4 different ways. Each of them is using different supplies. Why, right? So there's many ways that you can use this production wheel to study what you're doing. And we've written a lot about that too, and how we can use lean process improvement to enhance safety and value in orthopedic surgery, and particularly in this case, spine surgery. And really what we want to do is remove waste. And how we do that is when you remove variability, you remove waste, okay? When you standardize appropriateness criteria, you actually remove the variability between providers. You can make this transparent, multidisciplinary, and we've shown with our published data that you can improve the worst complications at least 3-fold. And the original Seattle Spine Team approach manuscript showed a 12-fold decrease in return to surgery in the first 3 months. So clearly we're improving safety for our patients. And that's why Toyota principles, the lean process principles, are really important to think about from a long-term perspective. So going forward, really, in the United States, we know that spinal surgery is in the national spotlight and that we need mechanisms to improve the safety, variability, and improve the cost of what we're doing. What's happening now in America is hospitals are pitted against one another to compete for these contracts. And the ones that have the lowest readmissions, the ones that have the best cost metrics, those are the ones that are chosen for certain contracts, right? And again, we have written a lot about teams, right? And I'm going to talk to you about risk mitigation strategy in more detail. So this guy, Stanley McChrystal, is the guy who planned the raid on Osama bin Laden. Okay, and he is a retired head of the joint. It's called JSOC, which is essentially the clandestine group that plans some of these crazy missions, including the one that caught Osama bin Laden in Pakistan, I think about 8 years ago now. And so we invited him to our Spine Safety Summit in 2018 to teach us about team building, right? How does it work when you lead a team in a very dangerous mission to go forward. And I learned a lot from him. And actually, if you really want to learn about really building and running an effective team, I don't think you should read medical literature. I think you should go outside of medicine and maybe look at this book that he wrote called Team of Teams. And you can see it's a very, very interesting read on how to do that. Teams combat stress situations in many arenas, and I put two very interesting things here. On the right, it's a maybe planning this mission to catch Osama bin Laden, but on the left, maybe it's a golf tournament, right? These are stressful situations where people's future is on the line, and so teams combat stress. So in our field, right, clinicians may question the value of this team approach, arguing that multidisciplinary teams they cost too much, they have unproven values, they might erode professional independence. But I mean, if teamwork and coordination could be built into the surgical team, high-risk patients will have fewer complications and require less rehospitalization. So clearly, this has been written about in the New England Journal of Medicine 5 years ago. This is not spine surgery. This is other areas of surgery, but we clearly can redesign the surgical decision-making for these patients to deliver a much better product for them, right? And the idea is, by failing to prepare, you are preparing to fail, is the famous quote from Benjamin Franklin. And the team that can prepare itself can get to the next level, right? The idea here is, it's very simple, that many of these considerations cannot be handled by the surgeon's brain alone, right? The type of surgery, the osteotomy that needs to be done, vascular considerations, right? Should we be doing this as one versus two surgeons, minimally invasive versus open? What about the idea of staging and the coagulopathy and things like that? So we really have to go to a different place on this topic, and surgeons need help, right? And they need help from these teams to deal with this. And so by putting this old picture together, this is pre-COVID. Nobody's wearing a mask. We all used to sit in the same room and go through all the cases. Now we have abolished this conference live. It's on virtual only, and it doesn't have the same power, but we have to do this, I think, now, at least for the foreseeable future. And really, it allows for a learning environment also between all of the doctors and all of the younger doctors, the fellows, the residents. A lot of anesthesia residents attend this conference. It really helps them learn. So this is an interesting slide I'm going to show you. I got this slide from one of my colleagues, right? And if you look here, right, there's a couple of interesting points here, right? If you look, all of these things, okay, what does this all mean to an anesthesiologist who maybe comes into your room once every 6 weeks? Just take a look at. I'll give you a minute to take a look at these terms. What does all this mean? They don't know, right? So if they can't spend time with your team in a conference setting to learn the difference between VCR and TLIF, these are two totally different operations with two totally different bleeding profiles. If they don't know the difference, how can they prepare the patient the morning of surgery? How can they adequately come to a proper level of understanding around what the dangers are going to be for that day? Pedicle subtraction osteotomy, one of the most difficult operations, just like a VCR. They need to be involved in the decision making on these patients well before the morning of surgery. And obviously we look at the patient on the left and the patient on the right, but there's all of the stuff that happens in the middle that is really, really important. And that's where the coordination of the team is very, very important to get from left to right so that you can reduce all of the error and waste that we've talked about. So who's in this conference? We have presented, in that 7-year period, 1,540 patients from all regions of the United States. And this is actually dramatically increased as time has gone on. We have taken care of patients from all 50 United States in our center now. This involves complex spine surgeons like myself, other orthopedic surgeons, neurosurgeons. It involves anesthesiologists. It involves rehab doctors. It involves a neuropsych assessment. As some of you may know, we published a paper on that recently also, looking at the neuropsychological assessment of every patient, and it has some very interesting findings, which we can discuss during the question and answer, but essentially that these patients carry a very, very high psychological comorbidity. So this needs to be assessed before surgery. Internists, pain management doctors, our professional spine PAs, our physician assistants, critical care doctors, research personnel, and even some of our local community spine surgeons. They come to these conferences to be involved and bring their own patients. Every patient that is presented has a note like this that goes onto the electronic medical record. This note is required to go to surgery. So as you can see here, this is the conference note. The patient was presented, the representatives of the departments that were there. Here are the concerns. This patient is smoking, needs 2 negative urine tests to document no smoking. We would like cardiology to see the patient. And basically, this needs to be completed prior to going to surgery. So this is a visual tracking point for the patient. And I have a picture of the guy who's been running the conference now in Seattle for the last 5 years. He's done a very, very good job on that. Going forward. So I'd like to show you some cases. I'd like to show you why this conference is very, very important and why we, are having a harder time maybe doing this surgery without the conference. Here's a 71-year-old lady, severe back pain. Her ODI shows she's very disabled. Sorry about that. She has osteoporosis. We have been unable to get the insurance company to improve Forteo teriparatide for her. An endocrine service has been unable to improve her bone mineral density. This lady is presented at the multidisciplinary conference 2 or 3 times and does not pass for surgery. She does not get this spinal deformity corrected, right? And so this is something where, we are very, very clear that, the team approach using the multidisciplinary conference lets us get to a very, very important level of care on her. Here's a 55-year-old female who's had 14 previous spine operations. 14, yes, that's possible. Multiple non-unions, continues to smoke, has urine cotinine that's positive. So she's essentially lying to the team, telling her she stopped smoking, but she's continuing to smoke. She needs 2 PSOs in order to get her aligned properly. This is a big, big operation, okay? We, on this case, do not perform surgery until she gets the smoking fixed and until we are able to get her to a much, much better place vis-a-vis her smoking problem and the fact that the team has to agree to surgery. So this is another case where we have delayed the surgery based on the multidisciplinary conference. Here's another patient, 67 years old, badly disabled, severe deformity, nobody at home. Our neuropsychological evaluation reveals a code red. You can read the published paper to understand what that means. But it means basically she has a very high psychological index. This patient needs a significant correction of her spinal deformity in these planes. And the team felt, no, at the first level, we needed a lot of work on her from a psychological perspective to get her ready for this surgery. And so at the first presentation, it was no. We ended up doing her surgery 1 year later after what we called the psych optimization, right? And again, there's no way that a surgeon like myself, or many maybe surgeons listening to this call, have the ability to do these things unless they build the teams to do these things. And that's a really key point here, is that these surgeries, obviously the only option for many of these patients is the surgery, but the surgery can be delayed until the patient is optimized going forward. And that's really the point of a lot of what we've done in the last 10 years. Now, I'm going to talk to you more as we go forward with the whole idea of predictive analytics and making this even more specific. But you cannot do, what's the point of doing predictive analytics if you don't have the proper team and proper organization to take care of the patient, right? So you have to start with this work first and then do the predictive analytics second. It's very well known that you can boost medical judgments by pooling independent judgments of the best doctor in a group. So that means the more people thinking about this, the better. Now, predictive modeling, okay? We have also started a foray into this, and it works, right? There's no question that there's something real here, right? If you take a 60-year-old female who is fat, who has anemia, right, who is diabetic, in our database, she has a 92% risk of having complications within 30 days of spine surgery, right? So what does that tell you? That tells you that these are very, very key risk factors that we need to optimize before we go forward with any type of surgery. That's a very, very key thing for us to do. The opposite scenario is if you take this 60-year-old female who is a normal body weight, who does not have anemia, no hypertension, no diabetes, does not smoke, then maybe in this patient, we don't have to do all of these processes of repeated multidisciplinary presentations or stuff. This patient can go directly to surgery, right? There's an extreme example for you just to see that these system-specific calculators or these predictive calculators are going to be important for us to make this even more specific going forward, right? And basically, one of the key areas, right, of doing this is using enabling technology, right? Now, I know that a lot of our colleagues are very, very interested in artificial intelligence and machine learning. That will definitely also help us. We need a lot of data, and I think that the fallacy in people's minds is that, oh, all of a sudden the calculator is going to help me reduce complications. I'll tell you that if you don't have a well-oiled team, if you don't have a process to optimize patients, and you don't have a process to do prehabilitation, you don't have a process to improve the substrate of what you're dealing with, the calculator means nothing, right? The calculator is just helping you figure out who to do it on and in what dose, right? Potentially even what dose of surgery. But remember that all of this goes together. And I put the idea of predictive analytics under enabling technology, right? Because it's going to enable us to do a lot safer surgery. However, that goes with robust post-operative processes, that goes with intraoperative safety and risk management protocols. It goes with preoperative multidisciplinary teams and risk analysis, particularly how to optimize patients. I mean, you can't optimize a patient unless you have the mechanism to do so. So that's where this is important. It also involves, things like capable people, right? That's the example, the military example I gave you of really assessing important military principles of how you put good people together and effective processes. So we've done a lot of this work in the national and international levels. I think this is another paper which I would invite you to look at, which is how you improve complex pediatric and adult spine care while embracing the value equation. This is a international group of people that we really put together, really to look at a lot of the things that we have done over the last many years. And a lot of this really is how do you go to a restaurant, right? And there's so many things that have been written about now about how to modify risk and how to make the surgery safer. You can pick what works in your system, right? And start in a slow way to utilize some of these areas for your own patients. And you're able to then take a lot of these areas and take them to new levels. So in conclusion, I believe that standardization really enhances patient safety. That's the key message here is that we have to remove the variability of what we're doing, right? There's a lot of new technology that can help you do that now, right? There's pre-planning software for you to measure your alignment. There is a big effort now at predictive analytics. There is now computer-based software that can help you track comorbidities in your office, right? These are all important steps for us to standardize what we're doing, right? And really pathways, protocols, and dashboards can really help us enhance what we're doing. I do believe that high level medical center administrative support is very important to do this. If I go back and I look at some of the processes here, technology is very, very important here, but technology is expensive, okay? If it's things like regular evaluation and business process reengineering, utilizing a method like the Toyota system, you need your highest level people in your medical centers to really sanction and approve these things. So that's going to be very, very difficult going forward unless there's significant investment. And really, if you think about the algorithm that we've talked about, right? The algorithm really is important because of this improvement model, which we talk about here on the left, which is that really all of this goes together, right? You're taking high reliability science and continuous improvement. You're taking the idea of organizational collaboration, leadership, and governance, and then systematic and standardized process and outcome performance measurement, and putting them together in a continuous circle. And once you do that, you're then able to really do quality improvement at the highest level. And that's what we've been talking about for many, many years now. And that quality improvement is going to be, I think, here to stay going forward. Remember that one of the difficulties with a lot of this work really is how do you sustain such a thing? And we can talk about that during the question and answer period. But it's really important for us to figure out what the algorithm for change is. So we have to do better, right? We have to choose patients better. We can't fix everything. We have to say no much more than we currently do. We are already seeing a dramatic scale of improvement in centers that do this regularly, that employ these models. They get paid better in America than the centers that don't do it. And I think that will continue. That's been around now for 5-6 years. It'll continue to improve. And I think you'll continue to see improvement in that area. One of the efforts that really is important though here is that I really feel that the surgeon should lead this effort. The surgeon should be really a front and center part of this going forward, because you know, we cannot let this be driven by hospital administrators who don't understand what we're doing, who don't are not involved with these patients, you know, from the get-go. So we really need to have this effort led by our surgical partners going forward. So that's just a ploy for me to say to you, please get involved in this work. Thank you for the opportunity today, and I'll be open for questions for the next 15 to 20 minutes.
Hi, Dr. Sethi. Congratulations for your talk. It has been marvelous. I think we can start with the questions. We have some here, like when you were talking about making the surgery or not, and you say that you need more than one opinion for more than one surgeon. How many should be the number? And if you have so many criteria from different surgeons, how to set the criteria?
Yeah, I think that that's a very important question, Salva. I think that there's a couple of ways to look at that, right? I don't think it's an actual answer for just one. You know, it's not just an answer for just one center. For example, right? In certain centers, you might have 6 or 8 or 10 surgeons, right? You know, you might have, you know, 2 surgeons, right? You might have 3 surgeons. So the number really is not, it's not a direct number. I think it's really something that you can decide center by center. I think the key issue is to really decide on the guide, the principles. The principles are, this is what we're doing. We are not operating on smokers. We're not operating on people who haven't had optimization of bone density, right? I think it's really a pre-planning event. The numbers don't matter. It's really that you have foundational principles upon which you're making decisions.
You mean like a standardized protocol that everybody follows?
Correct. Correct.
Okay. When you were talking about having in your multidisciplinary team a psychiatrist or a neuropsychologist, the question is always for every spine surgery or only for the really complex spine surgeries?
So we're only doing that for the complex spine surgery because it requires a lot of resources. Now, for the simple spine surgeries, we also, for fusions in lumbar spine, we have a pathway and we have a conference. But that's a lot more simple in terms of making the decisions than the complex surgery. So the complex surgery requires multiple presentations. And clearly, you know, needs a, you know, an important move forward, right?
Yeah. There is a question about when you say no to a patient, how can you, how do you say, how can you justify the no to the patient with a color code, something that is reflected in the protocol, because the patients, they didn't understand very well the no?
Yeah, I think that one of the things that we do when we say no is we sit with them and we actually go through the notes. Sometimes it's the color code, but we really try to explain to them why the team felt that they shouldn't have surgery. And I think that it ends up being you know, a important way to connect with them, because as you said, I agree with you, they don't necessarily understand why this is happening. And so really sitting with them and having them understand why that is a very, very important step, you know, for the patient. Most patients, in my experience in the last 10 years that we've been doing this, they don't really push back. You know, know that that we have really studied their history, that we've spent a lot of time on this, and that we're doing this for their benefit, right? Many of them want the surgery, but they also don't want to have a stroke or to have a major complication and have a long-term issue.
Yeah, so they understand that there is a lot of work before or behind.
That's right. That's right.
Yeah. Okay, we have two questions about the calculators. Where do you put the limit for the no? More than 50%, more than 60%, more than 70%?
Yeah, so that is a question that I think is also up in the air. It's really dependent on the surgeon, is dependent on the center where the surgeon works. If you decide that your threshold is 50%, that's what your threshold is. There are times when we have patients who we know have a 90% or 100% risk of complications, and we still go forward with the surgery, just knowing that that's the case. Now, where those calculators are important is in the era of value-based healthcare. If you are doing the surgery under a warranty or under a bundle, right, you won't give a bundle for that case, right, because you know that you're going to have complications. So that's where the calculators are even more important going into the future.
Also, is the calculator the first step or the last one after doing all the multidisciplinary work?
I think it's both. I think it's the first step. And then hopefully after you optimize the patient, it can be the last step too. Now, the question is, you're not going to change the fact that the patient has diabetes, right? You can just improve the control of the diabetes, right? But you can definitely smoking is yes or no, it's binary, right? I think it's I think it's an important thing to think about, right?
Okay. There's a question about how do you do if you have not the administrative support that you said that was necessary to do all this work?
Yeah, so I think that's a common question. I think that one thing you can do is, if you don't have the administrative support, you can actually start to take parts of it that you can do on your own, and so again, I go back to smoking. That's a big problem, right? You can do that on your own. Your nurse can do that in your office. Things like bone mineral density. There are psychological tests that you can deliver on your own, right? To these patients to really get them to a much better level. So you can do a lot of this without the team or without the high level conferences, etc. On your own.
Okay, we have one question about taking into consideration the current pandemic situation. What is your view about telemedicine technology? Yeah,
so this is a very good question, and we've written about this in the Harvard Business Review twice now. We have two articles actually in the Harvard Business Review, which which are actually free. Salva, you can actually send them to all of your colleagues. The first one we wrote about is the actual use of telemedicine for patient visits. Very important. I mean, very important. And I think it's here to stay. I don't think it'll ever go away. I think that going forward, right, we are the importance of this is really things are going to change after this pandemic, right? And many patients, they enjoy having the ability to talk to the doctor like the way you and I are talking now, right? That's never going away. And so we write about that in the first piece. And the second piece also, in terms of physician education, in terms of continuing medical education, we write about how the SRS has done with telemedicine in the article. This was just published last week. It's called Reimagining Medical Conferences, right? you know, right now, right, traveling is impossible, right? But it will open up in a year or so. But even when it opens up, it's very expensive, it's very costly, it's very disruptive. Maybe you can just log on to an event like this and or see the recorded conversation or the recorded talk going forward. These are going to be much more kind of well recognized and well accepted ways of knowledge transfer going forward. So I think telemedicine, teleconferencing, virtual connection is here to stay in a big way for the future.
Okay. We have one question about the new technologies. Could they reduce the risk in the OR? Could these new technologies make possible to go beyond in the current risk limits?
Yeah, there's no question that technology is a very key part of what we're doing. You know, I think that it's a very interesting and important way forward for us. You know, that can be something like simple as navigation technology. That can be something like pre-planning your surgery, you know, measuring your angles, could be pre-bent rods. There's so many ways for technology to go forward. I think it's an important, very important area for us going forward.
Okay. What are the new technologies that you have added to your armamentarium recently?
Yeah, so recently, you know, in the last 5 years, vis-a-vis navigation, we are using 3D printed guides. They're called Firefly guides from a company called Mighty Oak. We are using also O-arm-based CT navigation for cervical cases and some pelvic cases. We are utilizing the Medicrea software extensively for planning spinal deformity correction. We're utilizing obviously the pre-bent rods that come from Medicrea. We're also utilizing new computer-based platforms. There's several of them in the United States available for tracking patient-reported outcomes and keeping everything in a centralized database kind of fashion. So lots of new technologies like this to enhance the safety of these patients.
We have some questions also related to the current situation we have. So has the pandemic, or what is your, how does affect the COVID to your risk decision under current circumstances?
Yeah, so we have very strict rules around COVID. Every patient that comes to the hospital is tested for COVID. We have had to delay patients as just in the last 2 weeks, I've had to delay patients because of COVID. My general understanding is still that, you know, we don't know a lot about the long-term effects of this disease. So my recommendation would be, you know, at least if somebody has COVID, you want to delay the surgery at least 1 month, maybe longer. The one that I have, he was completely asymptomatic and never had any symptoms from it. If you've had somebody who actually got sick with the disease, my recommendation would be to really delay the surgery for much longer, because you just don't know what the cardiopulmonary effects are going to be if they've had significant disease. If they've been asymptomatic and it didn't do anything for them, that's a different discussion. But I think that you know, one of the biggest areas in my medical center in the last year with COVID has been convincing patients that it's safe to come and do the surgery. Because when we opened again in end of June, patients were not comfortable coming to the medical center, and so that's one area, you know, where we really have had to go forward, you know.
Yeah. Do you also evaluate the risk for being positive in the future, and how is considered the past positive patients?
Yeah, I mean, we definitely do, and that's an area that, you know, is of active consideration. That we tell patients, you know, if you're going to go into an area where you're going to be positive after surgery, you got to be really careful. we don't have skilled nursing facilities available in Seattle right now because it's just they're closed basically. So the patient has to go home from the hospital. So that's a very important decision point. And again, if the patient has had COVID but had no symptoms from COVID, then I would say once they're COVID free, you can go forward. But if they had symptoms or they had hospitalization or they were sick from COVID, I think that spinal deformity surgery should be delayed for quite a long time until we know what their health state's going to be. And I don't, again, for people that have had the disease or had it in a significant way and they were hospitalized with it, I don't think we know what the long-term sequelae are at this time.
Okay. I think this is the, let me see, is the last one we have here. Is your team being more restrictive under the current circumstances, or are you operating less because of these additional factors?
Yes, we're operating much less. Yeah, and I think that so what happened, at least right now in the U.S., is we are in a big spike right now, right? And everything is closed. In Seattle, all the restaurants are closed, all the gyms are closed. It's really minimal activity is allowed. So it's not a total lockdown, but it's pretty close. So you can imagine patients are not very excited right now to have surgery. And so that's the main reason, actually, I think.
Okay. We have not more questions. So I think it has been a real pleasure to have you with us to talk about how to mitigate the risks and try that not only the surgeries are most cost effective, but not to give the patients more problems after the surgery.
Yeah.
So I think that the audience will have the chance when we record the webinar. So everybody that has not attended could also have the pleasure to hear you talking about this very important issue about how to mitigate the risk in the risky spinal deformity surgery, which is risky only for the surgery.
Okay, well, I thank you for the opportunity. I send my regards to you guys, and hopefully next year we meet soon. Maybe in the fall of 2021 is what I'm thinking.
Yeah,
maybe that's
we will try to prepare meetings, and we will try to be in the congresses once the situation is over. So I think we will have the chance to also invite you for more scientific activities like this. And we will have more opportunities during the next year to do more webinars on different issues that you think that could be good to talk about to the audience.
Okay, very good, very good. I send my best to you guys, and have a Merry Christmas and a Happy New Year.
Okay, Merry Christmas to all your family, to you, to all the audience, and stay safe.
Okay, bye-bye.
Okay, bye-bye.